Just to let you know, today's session is being recorded for GP Excellence to host on their website, so that may or may not make a decision on whether you want to have your cameras on or off. We're starting just after past when everyone's had a chance to join. Okay, we'll get going. It looks like it's going to be a relatively quiet session today. Not too many on here. We are recording the session for going on to the website at GP Excellence so that they've got hosted videos that anyone can watch at any point. Today we're talking about succession planning for managers, and this is relevant as for the video on 2025-2026. Not too much changes on that. So to go through housekeeping, try and think of this as face-to-face as much as you physically can, but do ensure that you are on mute for background noise, particularly as we are recording, so that we don't have that sort of muffling that comes through sometimes when people aren't on mute. There will be a chance for Q&A during the session or at the end, whatever is comfortable for you. So as we go through something, if you want to ask any questions, please feel free. If you feel more comfortable typing them into the chat, that's also fine. You will be sent copies of the slides and several handouts after this session to help you organise and sort a succession plan for your surgery. Do let me know if there's any issues with the slides. I'm doing this from Lancashire and we have a raging storm outside, so just in case there's issues with Wi-Fi, please feel free to type them in the chat so I'm aware if suddenly I lose connection or anything. I'm just very mindful that the weather is looking quite frightening out there. If you haven't been on any of my courses before, my name is Luann Stewart. I am a practice manager of several areas over the years. I have recently retired, but I am back already locuming because any of you in practice management will know you can never quite escape. So I am doing some locum sessions over in Lancashire. I train and mentor for the Lancashire Training Hub, the LMC, and also for Manchester GP Excellence, as you are seeing today. I'm also a private consultant on estates, so I don't really know how I've retired, but I have tried. And just before I retired, it was very important for me to organise with my team a succession plan, something I've been doing for quite a few years, succession planning. It's not something you just do as you're ready to go, but it was certainly came in very, very useful. So what we're going to go through today for our discussions is how to make a written succession plan. We're going to look at the clinical team and think about that, and the administrative team and think about how we can succession plan on our admin team, but also, and most importantly, I think, is our management succession planning, something that all of you need to really start considering because we never know what's around the corner. And that doesn't necessarily mean leaving, it can mean jobs increasing to such an extent that jobs start to split. And if that happens, you do need more than one person trained up in a management position, so it can be really, really important. Anyone else like to add into the chat if you don't want to come off mute, which I can fully understand? Who else, who you think may ask to see a succession plan at any stage? And I don't just mean within your surgery, not just your doctors or your partners. Anyone have any ideas who asks about succession planning? I'm hoping somebody's typing. Yeah, CQC and the ICB. Absolutely. CQC are now asking to see successions plans, and that is part of the leadership part of CQC to make sure that you are really leading your teams correctly, and some of that is organising for the future. The ICB when they do ICB visits around, can often ask about succession planning. And it can also be an issue if they feel that something new is happening within your area. And you may not be aware of that. I certainly know that many years ago, I had the ICB asked to see a succession plan when they were aware that they were going to be removing a contract from a nearby surgery. And they wanted to see the local surgeries to that particular surgery who was in a decent position to step in and assist when all those patients found themselves without a doctor. We had a good solid succession plan. I had potential people training for management who could step in into an APMS contract and run it with my guidance and help, because they were half trained, and that succession plan gained us an extra surgery, an extra 5,000 patients. That may be something you would want, maybe you wouldn't want, but it was certainly something that the partners wanted. So it was very useful. I had that in writing at the time. All things to think about. So when we start to work out our succession planning, certainly when you are looking at your clinical planning, it is good to not be sat doing this on your own. Also, not necessarily just with your assistant manager. You should be joining forces with the partners, because this is their succession plan. They own the business, and unless you're a managing partner, you probably don't own the business. So therefore, they should be spending time organising a succession plan with you so that they fully understand how their business can work and how their business is looking going forward. And the discussion to have with those partners. So particularly if you have divided up your partners into different job roles, you may have an HR partner. I know some practices work like that. And if you do, it will probably be your HR partner, or it may be your lead partner, because they are the closest to retirement normally. So not always, but normally. So sometimes they would be the one that starts to want to think ahead of what would happen if they left, because there needs to be a succession planning for every type of job role. So when we go and start working through this, arrange some time with whichever would be the suitable partner, preferably a partner that has got some time to sit with you, not a rushed 15 minutes. This needs to be probably a good couple of hours of working through who you've got in your current team and what you can do going forward. Obviously, this depends on the size of your surgery. If you've got a very tiny surgery, single hand are more worrying if there's no succession plan. If you've only got, say, a couple of partners, a nurse, couple, 6, 7 receptionists, and 2,000 or 3,000 patients, it might be a different kind of planning. And certainly if you've got a single hander, you do need to think what would happen if they go. So when we get to the partnership bit, we will look at that. Also, if you have done the how to make your own business plan training that we have sorted out for you all, and there is a video of that within the suite of videos for GP Excellence. So if you haven't and you want the templates and everything on how to make a proper business plan for your surgery, within your business plan there should be a whole section on succession planning. So any of the work that we've worked through today, when you get your templates for this and you do get your template for your succession plan sorted out, you can simply embed that directly into your business plan. But there is also a template for that you can get when you watch the video. So we are trying to work you through so that you get every possible bit of training to make sure that you've got all of your business working right. Because when they look at leadership within CQC, they will look at the partners, but they will also be looking at all of you. And we want to make sure that you are coming across really well, because this is really about practice management training for you all. So when we are looking at moving forward, the first things to start thinking about, and really I would do all this bit without sitting with the partner so that you've got notes in front of you, because they won't always think in the same manner as we will, is look at your workforce and think about the next 3 to 5 years. So we're not thinking really, really long term. We're not thinking 20, 30 years, but 3 to 5 years. And what do we need to consider? Well, we need to look at age of people. We can't make any sort of decisions definitely on that, because people can work a lot longer these days, but it's also the type of people that you know Are they planning to retire? They often talk about retirement. Are they getting to an age where it is possible? You are not forcing anyone to retire by putting details in a succession plan. We are just thinking ahead. It's also a fact that as we get older, we are more likely to get sick, and long-term sickness is something that can be covered within your succession plan. So that's really quite important to consider things like age. But then we can go to the other end of the spectrum and think who is of a age and who is interested in, perhaps talks about pregnancy, maternity, or adopting children. Most people chat about these things. Again, you are not assuming anything, but you are making a bit of a plan around what would we do if they went off on long-term maternity? Have we got plans in place to cover that? So that is your short-term succession, because they will hopefully come back, but you have also got that long-term plan in there of getting people ready to take over those roles as and when it's required. And when we do make that succession plan, most of you will have this in your head already. You will be thinking, oh, if this person goes, we've got this person trained up. It's making it formal. So when we make it formal, we do ourselves a proper formal plan. And that's normally just a table on a Word document that you can type in and out of. And we look at 1 year, 3 years and 5 years. And we look at all the different work groups within that. So our GP partners, our salaried GPs, every different level of nursing, things like pharmacists, practice admin, and of course the management part of your team to make sure there's training in place for them. So when we're looking at that workforce we already have, we need to think about, is there anyone that is really suitable that we can move onward and upward? And the reason we do that, rather than thinking, well, we'll just go out to recruitment, partly is time. It costs a lot of money to recruit, and it costs a lot of your time to spend in recruitment. The other issue with recruitment, of course, is by the time you are aware that somebody is leaving. I'm going to take a practice manager as an example. Practice manager hands in their notice. It will probably take a week or two for the decisions to start being made of how you're going to put a new manager in. Are they going to have that same position, or are you going to split the job into a finance and an ops manager? There's all sorts of work behind that is the thinking time. Then you have to put your advert out. Your advert may be out for a month. So we're already 6 weeks into what is normally a 3-month notice period. Then we go through the interviewing. Then we work through if we have a successful candidate, because not always, sometimes you have to go back to advert. But if we do have useful people that we think, yes, that would be the right person for the job, we have to go through the process of offering them the job. And then by the time they have accepted, hopefully, and put in their own notice, you are going to have a period of 2 to 3 months with no manager on site. It's harder with a manager because there's normally only one. So you need to have a plan for people who could temporarily step up within your succession plan, or better still, grow your own position where you are constantly growing someone that can step up to the next level. So for instance, with management, you'd be thinking about an assistant manager or an ops manager who wants to be the practice manager. If they don't want to be the practice manager at any point, and that's not their plan, at least if you have got people trained up that can take over as a temporarily sort of when the position is empty, so that the basic fundamentals can carry on, like paying your staff and paying your bills. So when we're looking at our future succession plan, a really good part of that is using your tools of appraisal. So when you are appraising your staff, and I know not everyone loves doing appraisals, and we might think, oh, this is yet another job. But if you spend that time actively listening to what people want or what they're interested in, you may find that some of your team that you hadn't really thought about are actually interested in something that they want to learn and progress in. And it's not always in the same field. So you may get people who are a really good receptionist who has actually no interest whatsoever in being a reception manager, but has really thought seriously about doing her nurse associate because she's interested in getting into something more clinical. Listen out for that in your appraisals. That's really important. And use any staff meetings you have to explain any up and coming areas of work that are coming through contractually, or up and coming roles that are coming through, even when they're ours roles, because that can be really useful to get people's interest working, and then they can go away and think about those kind of positions and think if it's something for them. So when we start planning, we start by doing a proper workforce plan. Now, there was a session on workforce planning that goes alongside this. That was done about 4 weeks ago, I think. Again, it was videoed, and that should be available on GP Excellence site if you wanted to do that. Have a look at that and then ask for all of the stuff that comes with it, which is all of the templates to help you do a successful, I can't get my words out, a successful workforce plan for your surgery, which is the first starting point of your succession planning. And when we do a workforce plan, we look at our current skill mix, who can teach, who can get people improved and better at, because they are ready to not just show someone, but properly teach someone how to do a role. So we have that full video for you to watch if that's helpful. And when you work through your workforce plan, that should help you decide on your succession plan. Don't assume because you have all people with perfect skills that you don't need to do this piece of work, because we don't always know if people are going to suddenly leave or get ill, or even that sort of hit by a bus thing that happens, that we have to think somebody could just suddenly not be at work ever again. So if protocols and things aren't written up that we can follow and learn from and have people taught to go ahead, you can find yourself suddenly in a position where you're in trouble within your workplace. So when you do the workforce planning one, you'll get something like this, which is a graph where you can work through your different workforce and the different sections to know exactly what people's skills are. And don't just think about the obvious skills. Think about really coming forward, and we have got a slide on this later, things like AI. AI, according to the 10-year plan, is going to be 2027, every staff member is going to have to be doing AI training and learning and using AI more. So if you've got champions in AI at this point, you can be getting your staff skills ahead, and then you can look at what might be future roles coming up within your surgery that you could utilize to make things different. Don't just think about traditional roles. So for instance, it's quite common now to have a comms person in your team. So not just an IT lead, but someone that deals with all the comms, the social media, etc. I put one in place in my surgery maybe 12, 13 years ago when it was unheard of. But because you could see the changes coming up, we just thought if we can get someone learning that role now, this is a good position for the future. So that should help you if you look ahead, read that 10-year plan and think, what are we going to need going forward? And when you start doing your workforce planning, you have to map it all out. So look at your demand and capacity, identify your strengths and weaknesses, and improving your employee opportunities for promotion or diversifying into different roles. And when we're doing that mapping, we think about, as I just said, new contracts for the next 5 or 10 years, so we can start planning to succession plan around that. Ask people what skills they have. You won't always know if someone's really good at something if it's not in their current job role. So when we start to think about succession planning for our partners, we think about the next year, the next 3 years, and the next 5 years. Normally a partner, according to the partnership agreement, will have to give either 6 months or a year's notice. It's worth checking and finding out. It does take a long time to put together everything with the accountants when somebody leaves, organising, removing them from the mortgage, removing them from the land registry, and organising all their final payouts. What you then need to do is discuss with your partners who you would, if they want to still have the same amount of partners. They don't always want to, particularly if it's a heavy on partnership. There are places with 10, 15 partners out there. There are other places with 1 or 2. But think ahead, is anyone likely to retire? Or is anyone likely to want to reduce hours? And are you likely to want to bring in a part-time partner? Is there anyone that's going to need a significant amount of time off, possibly knows they're going to have an operation, maternity, or even sabbaticals? And you're going to have to think, what are those partnership things that we need to know, and have somebody ready in place? Are there any salaried GPs that you currently have, or even long-term locums that you think would be really suitable for partnership? And it is worth actually having that conversation with them, even though it's not available at this point, if that's where their plans lie. I know, having done this piece of work and thinking that someone would be an excellent partner going forward, when I managed to have a conversation very, very gently with that person, they had absolutely no interest in ever being a partner. So because of that, it was worth me then trying to open my mind and think about the other salaried GPs I had, and if any of those were likely to step up. It's also worth thinking at that time about local surgeries, if there is any consideration of merge, because that would again change the dynamics within a partnership. It's all worth getting ahead and thinking about these things so that we can plan these in our succession plan. If you've got a single-handed partner, this is really, really important. If that single-handed partner has any plans to retire at all, you could find yourself that your contract will be handed back to the ICB. Everything has changed with handing back contracts. It used to be that you had to have an APMS contract in place, and all the staff would be TUPE to whichever other GP surgery took that APMS. That is no longer the case, and contracts can be dispersed, the patients can be dispersed, and the staff can be made redundant. So if you have a single-handed GP, it is really important to know what is likely to happen if that partner decides to retire or has had enough. What are their long-term plans, and maybe talk about working through with any kind of merger in that situation if you cannot find another partner, because you don't want to be left with paying out redundancy and finding jobs for all your staff. And when we're looking at our succession planning, we do need to think also about our salary GPs. They're a good source. Where are they going to be in the next 2, 3 or 5 years? Are any of them likely to retire or reduce their hours? Or are they likely to replace an ongoing partner and become a partner, which could then leave you a void within your salary GPs? Are they likely to want some long-term time off, such as maternity? And this is the time, if you're a training practice, to start looking at those trainee GPs, or again, long-term locums, or even short-term locums that might be suitable to be a salaried GP in the future. It's again worth a casual conversation about their long-term plans, where they're thinking about going. I know that I've kept in touch with a few trainee GPs in my time, because even 12 months or 18 months later, as that succession plan has changed, going back to them and saying, remember when you were a trainee here, have you got any interest in coming to us? It looks like we'll have an opening. So it's always worth keeping hold of those details. When you start to look at your nursing workforce, because there's lots of changes going on with nurses, we've got to look at obviously retirement or reducing hours, as you do with every role. But we've also got to look at this new role that's come out this year for a consultant nurse position. It's currently available under ours. It is going to become bigger, particularly with these new healthcare centres that they're opening, and they are talking about consulting nurse roles being a major part of research. So are any of your nurses, have you got AMPs who are really keen to move onward and upward? And is it something you could accommodate, a consultant nurse role, or are they likely to just leave you and move on? To give you an idea, if you haven't read up about this role, it's paid at an 8C, so you are coming very close to a salary GP rate of pay. If you can see that your AMP is going through that training and is looking to then potentially leave you, you need to think very seriously if they're a really good member of staff. Is it worth speaking to your PCN? Can you do something to keep them in that consulting nurse role? Or if it is just too much money, you're then going to be short an AMP. And what are you going to do at that stage? Are you going to go for another AMP? Or are you just going to go for an AP and look at an advanced paramedic or an advanced pharmacist that may be able to fulfill some of the areas of the role. Upskilling within the nurse team is something that generally, apart from that AMP up to consultant nurse, because that's so new, all your other upskilling is really worth looking at doing in-house. If you've got a good member of staff that you don't want to lose, you will lose them if they want to move onward and upward. So to look at that succession plan, if you have a salary GP perhaps who is leaving, you can think, actually, would that be better with an advanced nurse practitioner filling the role, which may be a little cheaper for you as well, or they can see a few more patients. So have a think about changes within your succession plan. Also look at your age of your nurses. I know I've worked at a practice where all of the nurses were going to come up for retirement at the exact same time. So we got to a point where we were having to look at bringing in some younger workforce and more nurse associates so that we had some kind of succession planning to work through. So have a think about that with your nurses. Also, if any of your nurses are wanting to upskill to that AMP role, that might be really useful for you in the future to cover maybe what has been a salary GP role or an AMP who has left, or to cover more work coming in, perhaps other surgeries closing or lots of new houses being built. So if you have any nurses that want to upskill to that advanced nurse practitioner role, it is worth, if they are a good quality employee, looking at keeping them. And can you do that training in-house, which generally you can. You do have to give them some time off, but there is some funding for that quite often. The other really good role that's come out in the last few years, often under ours, but you can also take this role as a just employed by you, is the nurse associate role or the trainee nurse associate role, which is often an HCA that wants to train to be a nurse associate. There is a lot of free training money out there, but you do have to release their time. You don't generally get paid for the release of time, but you do get paid for all the you get all the training money for them to run through the university courses. So you need to think about, again, the next few years. Are your practice nurses coming up for retirement? Do you want to grow your own? Often nurses that come in to practice nursing from hospital find it quite a challenge. So it is quite good to keep someone that's been, say, an HCA, move them through their nurse associate. Once they've got their nurse associate, they have a PIN. And when they have that PIN, that means that they can do various things that an HCA can't. Things like if they do their cytology training, they can take smears, they can do a lot of chronic disease working. So they are like 3/4 of the way to being a practice nurse. So there is a 2-year top up after the nurse associate to make them a full practice nurse. But again, if you know that staff member, you can put that in your succession plan that you are training them onwards and upwards to keep them, because keeping them is much cheaper than recruitment. And then you know that staff member and you know if they're the type of people that you want to keep. If you have got money left within your arse, you can take on a trainee nurse associate for a band 3 or a qualified nurse associate as a band 4. And then they only need that 2-year top up that we've talked about. If you look at your local training hub emails from your Manchester Training Hub, you will often find that there will be bits in there that will give you details on free training that will get them topped up. They do spend a lot of time out in placements, which can be a bit of a worry sometimes, because you may have to then cover that. But that's when you start looking at any receptionists who maybe have some interest in learning a bit of phlebotomy, just to keep some of those appointments going. So then you can have a full plan up from maybe a receptionist learning phlebotomy, a phlebotomist who wants to be an HCA wanting to go into nurse associate, and nurse associates going to practice nurses. If you can work through all of that and keep your current team, you will find in the long run it is a lot easier and cheaper generally than going through the full recruitment process. As we mentioned before, AI training, all of staff, clinical and non-clinical, are going to go through AI training by 2027 in the 10-year plan. So if you are looking ahead for that, That's where we mentioned before, get your champions sorted out now and start with some basics. Look at things like Heidi, all of those kind of things that are out there. Look at Copilot for doing your minutes, anything that can save you time. That can also be your succession plan. Doesn't always have to be people. It can be a machine that's coming in or AI that's coming in to replace certain parts of someone's job to make life easier as you work forward. And then the big one, and the one that we all need to be doing, and that's your practice manager work. So have a real think about how good are you at delegating. I know it can be a real struggle for some people. Some people find it very easy. If you can learn to delegate and teach your team as you go along, you don't always have to teach just one person. You don't have to plan that one person will be the only person that will be able to sit in your role. You can divide bits of your role and teach different people. And also have all your policies and protocols written up of exactly how you work, how you do, say, payroll, how you pay bills in the bank, how you reclaim your water and your rates, just so that somebody else can pick that up. So I personally, about a year maybe before I left my final role, and I knew that the long-term plan would be to take early retirement, was to start to put together my own handbook of how you did each part of the role. If you're a member of Practice Index, they do have a handbook, but it's very generic and you need to be a little bit more surgery specific because we all use different products. So for instance, your payroll may be completely different to my payroll. But if we can work through and work out exactly in a protocol how we do every part of the job, then that can be passed on to someone and you can teach different people who have the right skills. So train your team, learn to delegate. And it's probably the hardest part of your succession plan. And that's because there is normally only one main manager within most places. Now, some of you who work in really big practices may have a finance manager and an HR manager and all sorts of other managers. And if you do, that's great, because as long as you can co-cover each other's jobs and you understand how to do that, and we only understand by doing things vaguely regularly. Even if it's once a month, somebody does 1 week of the accounts just to keep their head in so they understand how the account system works, then it will work going forward. If you just show somebody once and then 2 years later they have to pick it up, it will be a lot harder. So make sure there is adequate cover for each part of your job, set those protocols up, get that handover document made, and have some one-to-one training with your deputies, your ops manager, anyone that you think could start to lead a team. It's always good to have those team leadership roles, even in small practices. If you can just have someone that has a little bit of a leadership role, then they learn how to run a team, look after a team, and come back to you. If they want to do external management and training, there's a lot of money out there for apprenticeships that you can work with, and you can do an apprenticeship in that. There's also places like IGPM that you can work with to get a qualification, and I was just reading this morning that they've actually got they are going to be working directly with the government looking at our new contract. So a really good idea to be able to go through their qualification as well. So one good way of starting is to make a plan of your daily, weekly and monthly tasks that you do, and then ensure there is another person who can complete these. So what I've done is I've made a plan for you to complete, so a template that you can complete on your daily, weekly and monthly tasks, and that will come out with your paperwork for this. And that's for you to start really digging in and looking at your team, because then it will make you see your team in a different manner and you can get that succession plan really started. So complete these on a workforce plan so that you can plan for the success of the practice if you do decide to leave, retire, or you're off on any long-term thing. It's also a really good thing to be able to do in case new projects come along and you need to be able to take over that project, which will leave other parts of your role uncovered. So it's not just about leaving. Sometimes it's about the new stuff that we're all expecting to come in with all of our new contracts, and making sure that everything is covered and that we have some kind of plan for all of that. So that is why we succession plan, so that we can learn to teach people. The practice manager's role is normally the hardest one to replace, so that is really worth looking at. At the end of this year, so they've only got 3 more weeks, we are being told by the government there will be a 10-year workforce plan. That should be giving us lots of tips and hints on the kind of work we are expecting to see over the next 10 years, the kind of jobs that will be coming out and that will need to be covered. And when we look at that, that should give us some ideas on how our surgery is going to progress. We'll get that business plan that we talked about, that we had a different training on, and we can work through our business plan, looking ahead at the next 10 years. As part of that, as our succession planning for workforce. So we'll look at what needs to happen in the next 10 years, what workforce you would need to do that. So for instance, if there is, I'm going to use AI again, a big piece of work on AI that we're expecting to see in the next 10 years, we should start looking at the workforce we would need to complete that, and then look at our succession plan. Do we have current staff that will be able to do that? Any of you that did the 10-year plan, not the 10-year workforce plan, but the normal 10-year plan training that we did in the summer, you'll see that a lot of the next 10 years for GP practices is going to be research, and we are going to be expected to do and get ourselves involved in lots and lots of research. So for instance, for your succession and workforce planning, you could look at staff that would be good to work within research. Could somebody assist and do the paperwork for you, because it's going to be lots and lots of work? Is there somebody that you trust that's very accurate that maybe could do that training, and that can become part of your succession plan for new roles? So it's not just planning to cover you, it's planning to cover the new stuff coming through. So when you're making your succession plan, you sit with that partner and work through how you think the clinical team will look going forward. Talk to your whole team and ensure that all of your team knows and understands what is happening and what is going to be available in the future, and to find out if there's any interest from any of them on learning new skills to work forward. You form your plan on the template I've given you, or make yourself one, whatever works for you, and then discuss it with your partners to make sure they're all happy with the plan going forward. Bring it into a meeting. Add it into your business plan, as we've talked about, because that will be a whole section on succession planning. And then keep revisiting it, because people change their minds. So keep listening in those appraisals. What do people want going forward, and how is that going to work? It's time for questions. So while we do questions, I'm going to leave the upcoming sessions on. Some of you will know that we are planned through till March. At that point, I am retiring from training as well. So before I retire, they have asked me, because they don't have a full replacement for me yet, to do various different training sessions with you, and they're all up on your screen if any of them are of any use to you. And there are also various different videos on business planning. There's one coming up for resilience for staff, lots of different things, and you can book onto any of those in your normal way via the email for the GP Excellence team. So questions on succession planning? No? Anyone want to discuss anything they've got on their succession plan? You're all being very quiet today. I think it's because you know it's being recorded. When you get to the end of this session, which we are kind of there now, we will be going through everything coming out to you. I don't deal with that. Somebody else will be sending out everything to you. So that will happen over the next sort of 24, 48 hours. Normally, you will get copies of the slides. You'll get copies of all of the different templates. I would suggest you start working through those templates, organising your discussion with your partners on how to their feelings on succession planning, and looking ahead at your team to make sure that you have got a good quality planned team for going forward to keep that surgery running well. And also think about any big projects you've got coming up, because that's going to make a difference in who you need to cover those roles. But if there are no questions, I will let you go and I will stop the recording, and thank you very much for your time today.